Hello, Dr. Mahmoud.
Hello. Hello. Good evening. It's
Good
evening.
evening.
Eid Mubarak.
Merci. Thank you. Eid Mubarak, you also.
You're welcome. I guess we didn't meet before.
No, this is the first time.
Yeah.
You were working in Root and you did not meet Dr. Moher. Strange.
He did not speak for us in Dubai for a long time.
Yeah.
So I guess he spoke in Cote d'Ivoire.
In Cote d'Ivoire once, yeah. For
And,
before Root and Cote d'Ivoire for biotech also.
Yeah, and Bern, but I didn't meet. I don't know if we met in Bern or you don't remember me.
I
don't know.
was in Bern, yes.
Yeah, I know, but you don't remember me, I guess.
No, well, I don't know if I don't remember now if I met you. There was a lot of people there, you know.
Yeah. No, but I know like you're popular in Root, so
Oh.
it's fine. Yeah, so today I'm gonna pitch the course in the end of the webinar. So I'm gonna be speaking about I've just went through the course outline. I know the JBR technique. I'm gonna just emphasize how important it is, especially in when you place an implant. It's not about placing an implant. You need to have at least 1.5 to 2 millimeter around the implant body. It's not because you will have, the bone dissolves and by time and it's going to be exposure. So I'm going to speak about that. We have over 250 registered, but I guess we're going to get 100.
Okay.
Because now the conversion rate is never 100%. Like some people not show up, some people be busy.
Yeah.
So we're going to get around 100. So I'm going to speak in the end.
For a webinar, I think.
Pardon me?
Which is good for a webinar. It's very good, I think.
All the webinars I did are more than 100.
Okay.
I know how to bring people, so it's normal for me. If we make another, it was also short notice for me. I just marketed for 3 days.
Okay.
Next time, maybe I'm gonna get 1,000. So yeah, so we're gonna pitch it this way, and I spoke with Dr. Salman. I'm preparing a list of webinars. We will do a lot of webinars all over the year, and by the end of each webinar, we'll have a course to sell.
Okay.
Yeah, I do this with my local KOLs in the regions that I used to work in, and it works perfectly.
Okay.
So yeah, it creates awareness to the course more. It gives space to speak and discuss about what they're gonna learn.
Actually, I'm developing here with Olga our course in my clinic.
Yeah.
And Olga wanted to prepare something. She didn't send me yet, but she wanted to prepare something that we expose to people to tell them about our course. We are making here. It's an over-shoulder training. It is I take usually I take 2 to 3 person maximum, but Olga asked me to take 4 to be more less cheap for patients for doctors.
For participants, yeah.
Yeah, so we accepted to take 4, but it's only like mentoring course.
Actually, honestly, like I do a lot of courses. The problem right now is I don't know. I've been working for 3 years, but economically, it's everywhere hard now. I don't know how it is in France, but let's say the areas that we are active in, it's a bit hard. So that's why we're pushing for this, for the cost to be down. It's not because we think you're worth less. It's about ability of selling it or not. Like where I'm making courses, when the price is good, I'm able to get 10 to 12 per course. The quantity gets more. So let's say if I'm going to increase the price, I'm not going to get this.
But
it's like you're building your name also, in these regions.
Yeah, but the thing is that we are not looking to have a lot of participants. This is the idea. It's only we have 2 to 3 participants per course. This is our to have valuable time to be able to share the knowledge really for everyone on its level. Not something like a major course. We're not doing that. We did that in the past, but now we are not doing this. Now we're really taking only 2 to 3. It's like,
let's say if we get 10 people, how will we manage it?
10 people, it will be like as I did before. It's like we make a theoretical, then we make practical, and then we make live surgery, and that's it. Live surgery, They will be in the classroom, and I will be in my block, and everything will be transmitted.
Oh, you mean they will not be inside the clinic?
No,
Yeah, sure. It's never like
10% inside the surgical block.
No, it's never like this. We had today a course in Cape Town. People were outside. They were watching through the, there was like an intraoral camera.
Yeah.
It wasn't.
This is what I did. That's what I do.
But they got into three groups.
Almost. That's what I did almost. But now, no, not now. The participant will be with me in my room, and he will be operating with me.
Yeah.
This is the complete different story.
And is it permitted in France?
Yeah. I am the operator. But
they're just spectators.
No. He is helping me. He is helping me. He's touching the materials. He's helping. He's helping me. He's doing things.
Okay, then let's see how it will go. I was just reading the. It's like GBR for the single tooth, which is like.
Yeah, but I didn't know. I wasn't aware about this course. I'm telling you about the course that we were working on with Olga here in France. But Olga wanted to promote it through the webinar.
Yeah, we need to promote something through the webinar.
Yeah. So she was preparing something, I think. But I don't know where it is now.
I have no idea. But I just received this. I don't know. Dr. Salman has.
Yeah, I can ask her. And other thing,
one day course on graft and soft tissue management.
Talking about GBR.
GBR.
Yeah.
This is Dr. Moheb. We discussed it early February, if you remember.
Yeah, I remember.
The course started. So we wanted to do this course. We discussed this course before about soft tissue management, MPM, and with the.
Yeah, this is what I wanted to talk about. Talking about GBR, if you want to emphasize on something that we were the inventor of sticky bone, me and my teacher, which is called the MPM. We published the first on 2010 about it.
So it's about the application, actually. We can apply MPM in horizontal as well as vertical GBR.
Yeah. Now it is the sticky bone now, but at the beginning it was the MPM. It was what we published in the first me and my teacher. So this is what they are going to learn a lot, how to manage it, how to use it, how to prepare it, and all these things.
But for us as sales, for Ahmed, actually the topic of GBR, like horizontal bone augmentation, it works. So the title is actually according to to something which sells, and in this course we can actually pitch about all the techniques.
Yeah, I understand, but just only to tell people, if you want that, if you see that, if you think that it is benefit, to tell the people that we are the inventors of this technique of the sticky bone that is used in GBR. I don't know. It's up to you. It's up to you to do it or not.
No, we will plan it, because this is just a teaser, and the complete course profile will be released soon when there are inquiries. So whatever we discuss in February, I write it down and I gave it to Ahmed regarding the short course for one day. The next day will be surgery, live surgery, in which like you will be operating and people can see it from remote access. And this is actually the theme of the course. And we will start promoting. I know we are just late because we were supposed to do it in February. But we are already in May right now.
Yeah,
this course was decided already, we had a huge discussion
all what happens in the Gulf area and all these things.
Yeah, it was just because, like, you remember, we wanted to even record some good podcasts.
Yeah.
So, but unfortunately, never too late. We will still do it, and we will do it as we discussed.
So
promote it.
Not interrupt. One day, it's a one-day course that we're gonna do, right? Or 2 days?
It's a 2 days course, Ahmed. I think if you have read it, it's completely.
Because here it shows 1 day, the one short course GBR. So
yes,
I'm
it's 1 day. It's theory, and the second day it will be live surgery, which was written in the chat.
Okay, 11th to 14th. So it will be 12 and 13. Okay.
Yes.
What?
The course
for the delegates, not.
The one that I sent you, the brochure, Dr. Moheb.
Wait, yeah.
So I can't find the details of the 2 days. I want to read it.
The second day is a live surgery. The whole day will be live surgery, hands-on with live surgery.
Okay, so it will be on 11 and 14 September. Okay.
Yeah, it's a full day, 4 days, but the course will be on 12th and 13th.
Okay.
So here it shows 1 day course. The thing you send me. So is there any alternative? Because I need to know how to speak about it.
As I'm talking, the next day will be hands-on and live surgery, Ahmed.
Time slot. So first day hands-on and second day is live
No,
surgery.
Ahmed. First date will be lectures.
Okay.
The second day we will have a hands-on and live surgery.
Okay.
To have everything in one day, it becomes chaotic. We try to do it in India, but it's still
It's hard.
not so easy to do it. And because we are doing this in Europe, it's not so easy to do it.
And I think people want to visit a little bit also.
Yes, they want to travel, so they
Yeah.
need some free time.
Hello together.
Hi,
Hello.
Desi.
Everything set? Yes?
We are about to go live in like 1 minute.
Right.
We already have 16 people. We have from Afghanistan, we have from Greece, Iran, surprising,
Oh, nice.
India, Africa.
We need to check later with the participants. You can send me the list, so I will check later how we can upload it.
I'll send you the meeting attendance, okay?
Yep, perfect.
But it's only names. There will be no email addresses.
Really? Email should be there. All right, good luck, Doctor. Good luck, all the best, and thank you so
Thank
much.
you. Thank you.
So, Ahmed, we can start.
Yeah, you can start. I'll speak in the end. I'm not gonna moderate, okay? I'm gonna just propose. I'm gonna read the outline of the course, and I'm gonna prepare something to speak
Yeah,
about.
Dr. Mohammed, can you please check if you can share your screen?
Yeah.
I think yes, because you are the contributor.
It's 1 hour, right? It's 1 hour
No,
only.
I'm not able to share it. The message is that I am not able to share it.
Okay, one moment. I'll make you the.
But I have only 4 participants? No.
No. The 4 that you can see.
Oh.
Now check if you can. Dr. Mohammed, can you hear me?
Yeah, I hear you. Okay.
Yeah. Can you share your screen now, please?
Yeah, I can.
You can, right?
Yeah, but
Okay, perfect.
are you seeing it?
Yeah, I can see it. I just bring everyone in now. Okay. We already have 20 people.
Shall I put it on diaporama first?
Yeah. Perfect.
Okay. Are you seeing me? No.
Yeah. No, I cannot see your camera. Your camera is off.
Wait. Up.
You need to on your camera from this side.
Yeah. This is what I'm looking to do. Check.
Now
Okay.
it is.
Wait now. Check. You are seeing my screen?
Yeah, I can. Perfect. We can say it now.
Я там это гораздо больше по дороге. Дело видно сейчас. Глаза, это может налакать степи и так. Может налакать ей и пошли.
On voit sur mon téléphone. On voit sur mon téléphone.
Hello and good evening, everyone. Welcome to another beautiful webinar now. I know it was a long time and it was a long break since we did this webinar with Root. We have an excellent speaker with us today, Dr. Al-Maheb.
Ben non, je t'attends. Je peux
An
regarder en
excellent
attendant.
teacher.
Il m'a dit qu'il fallait pas que tu regardes.
C'est le match, mais c'est pas un match. Ça, c'est un match de rugby, ça.
Ah, d'accord.
Ça n'a rien à voir.
Ah bon.
You have to copy your mic. You have to copy.
Yeah, I'm trying to mute all of them. It's okay. So Dr. Maheb will actually talk about today the importance of implant designs and how you can achieve excellent results with the implant designs. And as you know, we already launched an amazing implant design with Viper, Root Viper, which was launched last year, and we had excellent clinical results, especially in terms of immediate loading and all the principles that followed biological design. And Dr. Mohib will deep dive into this design and share his experience and knowledge to give us an insight about how was his experience using it. So thank you, Dr. Mohib, for joining us. It was really nice. Thank you for your time, and I'll give you the mic without waiting any more time.
Thank you. So thank you everyone for being here at Saturday afternoon. It's a little bit hard, but here we have a lot of
Yeah.
So here we have a lot of it's very hot here. I don't know how it is for you. So let us a little bit discuss. We have 60 minutes to discuss about implant choice and the idea of the treatment by using the implant, and what implant should be used for what kind of treatment. Actually, what we all want to do is after. It's not working. Yeah, what we all want to do is once we place an implant, we like to have a stable result, a stable aesthetic result that's last for a long time. And the patient will be happy. Can you please cut your mic? We would like to have a special results that is stable all along the run. We would like to have results that it is like this 5 years after the implant placement. We are having a beautiful soft tissue, a beautiful margin level, and a stable result. The patient will be happy, and you will be really satisfied. So actually, the implants material evolved through the time. We started by the machine titanium implant from Denmark that works still now for more than 40 years, and then we started to make implant roughness on the surface of the implant, and then we started coating this implant by bioactive materials, but this bioactive materials didn't work. Then we developed the new alloys like TA6 titanium grade 5 and which is developed by Stroke. And at the end of the day, we got the zirconia implant. For me, the zirconia implant is not really. Can you please cut all the mics?
I'm trying to kill them, but
Yeah, because I have a lot of noise here. So the zirconia implant, for me, it's still not the ideal because of this elastic possibility. It's not very elastic. It's break. So there will be easy and plastic deformation with the zirconia implant, and it will break. So we are still now using this alloy of titanium. So the titanium is still the gold. As we know, we have several grades of titanium. The titanium that is purely that is pure is the titanium grade 4. It is considered commercially pure because it's the titanium that contains maximum of oxygen inside. The titanium has an excellent biocompatibility. It's because of the oxide layer. What this means? We all know that the oxide layer is giving this biocompatibility of the titanium. Why? Actually, we all know that every metal, once it's exposed to water or to air, it will start a corrosion procedure. This corrosion begins by oxidation of the metal. Once there is an oxidation of this metal, we will lose some ions, and this is the corrosion. Once we lose ions. So if we put an implant in the mouth, in the bone of the patient, and we start losing these ions, these ions will go in the blood circulations and will fix on the cell's defense cell. This will will induce an inflammatory reaction, and we will lose our implant. So what about titanium? Titanium, actually, this titanium oxide layer is very hard, and it stucks very hard on the titanium surface. So we are not losing any ions. If we are not losing ions, these ions will not go and fix on the defense cells. This way, the body didn't see the titanium, and the body cannot reject something that it didn't see it. This is how the titanium oxide layer plays a very important role. And this is why all the companies are looking to make an alloy that is very high resistant to the corrosion. Because the corrosion, any corrosion on the titanium surface, this will make a foreign body reaction, and we will lose the implant. The titanium, we monitor it 10 years, and the success rate is exceeding 97%. Can you please stop the mics? So it has a favorable elastic module that reduces the stress sheathing on the bone, because it has an elasticity module. This is different than the cornea implant. This is what we say. And the corrosion resistant, this is what we were talking about in the oral environment, will proven long-term stability. The more the implant, the more the titanium is resistant to the corrosion, the better it is. So as you can see here, we have some different grade of titanium, the 1, 2, 3, 4, and 5. The one is, let us say, one is the soft one, and the 5 is one. The grade 4, we say it is the pure titanium. Why they say it's the pure titanium? Because this is the one that contains maximum of oxygen inside. This is what we call it, the pure titanium, commercially pure. The grade 5 is a very hard titanium, because we added to the titanium, we added aluminum and vanadium. Then we got also the companies that added zirconium on the aluminum to make an alloy without aluminum and without vanadium, but having almost same hardness that the grade 5. But now what we have is the grade 23 ELI. What's the ELI? It's the extra low interstice. Actually, we have in grade 5, like the oxygen is here, the nitrogen is here, the carbon is there. And in the titanium 23, the distance between like the oxygen molecule and carbon is reduced to the minimum. extra low interstice. The interstice between molecules is reduced. This gives us the hardest titanium. And now company like Root is using this kind of titanium. Okay, you are going to tell me what is the advantage of this? This is a very big advantage for us as a surgeon. Why? Because actually, if you are using a titanium grade, let us say grade 2, like Onkylose, the titanium, the implant that you are using is a grade 2 titanium, and you are having a crest with 4.5 or 4 millimeters width. So you want to place an implant. If you choose an implant for 4 millimeters, 3.8 millimeters, 3.5 millimeters in the posterior, as in grade 2, it will not have the break because it is a soft titanium. While you are using the titanium 23, this allows you to use narrower implants in narrower ridge and do not go for bone augmentation. So you reduce time, cost, and morbidity. This titanium 23 allows us to place implants where in the past it wasn't possible to place them without any bone graft. So it is really interesting, this kind of titanium, and so we can use narrower implants in narrower ridges. And as I always said, I prefer, even if the ridge is big enough, I prefer, since I have this kind of titanium 23, I prefer to place a narrower implant than a big one. But why? Because I prefer to have more bone in the patient than more titanium. As you know, titanium we can produce a lot, but bone we cannot produce it. It's very hard to produce it. So the idea is to save the bone for the patient, to have more bone in the patient than having more titanium in the patient. So the titanium 23 is a very, very good product. The implant that the companies that are using titanium 23, such as Root, is very, very interesting. So as I said, in the past we have the machine surface produced by Brenmark, who was the first one to talk about osseointegration, but not only the first, not only he was the first. We got Tramonte from Italy with Tramonte screw. He also talked about, in the same time, and even maybe before Brenmark, about the osseointegration. But this machine surface, we transferred it in rough surface. Why? We will see why. This rough surface, we have different type of rough surface. We are not going to get in details of everyone, the cyanide, the SLA, the etched, the sandblasted, and we have the surface by addition. We are going to forget this surface by addition because it didn't work well, and we lost this plasma spray that is covering the implant, and we started losing a lot of implants. So this production was stopped, and now we are working on in subtraction. So we are having the smooth one, the machined one, and we start taking materials out of it by sandblasting and then acid etching, which is called the SLA implant. Okay, so what is, for me, a dentist, if the implant, the smooth surface is working, and the smooth surface with osseointegrate, and here we can see these osteoblasts fixed on the titanium surface, and if it's osseointegrate, why we need to go for rough surface? What is the rough surface for me? What gives me? Actually, the rough surface would increase the surface area, the surface implant area, the bone implant contact. In rough surface, the bone implant contact is bigger. So this allowed me to have shorter implants. So now we have two advantages of the shorter implants and the thinner implants. This surface treatment allows me to use shorter implant. In the past, in a smooth and machined surface implant, an implant of 10 millimeters is a short implant, but now we are having implant 4 millimeters, as Root are producing an implant of 4 millimeters, which is very, very, very impressive, and it gives us a lot of possibility to place implant in short, not a very high ridge, And it gives us a faster osseointegration. Why? Because of the wettability of the surface. The more the surface is rough, the more we have a wettability, and the faster the blood will grow on the implant, and the faster the cells will come and produce bone on the surface of the implant. So this is the importance of having a rough surface implant. The best surface, as we know, till now, it is the SLA. It's the one that is sandblasted, and then acid etched. It gives us the more roughness that we can obtain. But even with this, the bone implant contact is not more than 60% of the implant surface. Even if you place your whole implant in the bone, you get only maximum 60% of bone implant contact. But with what we are going to sandblast this implant surface? Okay, we machine the surface, the implant, we take it out, and we start sandblasting it. With what we are sandblasting it? We are sandblasting it. Almost all the companies are sandblasting it with aluminum oxide. And what is the problem of aluminum oxide? By the way, companies like Root are not using aluminum oxide. They are using hydroxyapatite to sandblast it. What is the problem? The problem of aluminum oxide is that there's always remnants of this aluminum oxide on the implant surface. We cannot clean it. It's not possible to clean it. And having this remnants of aluminum oxide on the surface, what is the consequence of that? The consequence that will reduce the corrosion resistance. Remember what I was telling you at first? I was telling that all companies are looking to increase the corrosion resistance, because if there's corrosion, we may lose the implant. So this remnants of aluminum oxide may reduce the corrosion. Pay attention, please. The aluminum oxide, is not aluminum ions. It's not the same. Aluminum ions we can find on the implant surface, yes, but aluminum oxide are not the same as aluminum. It's not the same product, but this aluminum oxide may reduce the corrosion resistance. And once the corrosion resistance reduced, we are going to lose ions that are going to be in the blood, and these ions are going to fix on the cells in the defect that will start a human reaction, an inflammatory reaction to reject the implant, or maybe I'm telling them, we don't know till now the moment yet. Maybe this is one of the part of periimplantitis. We don't know. Maybe it is. But what we know, what we are sure about it, is that it is reducing the corrosion resistance. The question of the periimplantitis around it is now a remaining question. It needs to be to have more research on it and to be fixed if this is a problem or not. And let us talk about the abutment connection. Why I am in love? I'm not telling this because I am here hosted by Root, but I'm in love with the connection of Root. Why? Because actually the connection between the implant and the abutment, it is the key factor of the choosing the implant. The connection is really something very, very important. Why? It is the first. It is the way. It's the part that it's communicate from the interior part of the implant and the exterior side here. It may have a seal or not. It depends on the quality of the connection and the type of the connection. Seal of the bacteria. It may preserve the margin from margin bone loss, and it is important in the aesthetic for the aesthetic outcome and for the stability. This connection is very, very important. We have 4 types of connection. We have the external X, which was in the beginning developed by Brenmark. It was not developed as a connection from Brenmark. It was developed only a way. It was a way to hold the implant and to insert it. But the companies worked on it and use it as a connection. Now we are still having this kind of connection in like the multi-unit abutment. It's a kind of external connection. It is easy to use, especially in several implants. If you're having several implants, you are making your bridge on implant and you want to make screw retained implant, the choice is the multi-unit abutment or the external X. It's still very, very easy to use. The internal X is giving us a better load distribution and giving us better stability, and which is important, less screw loosening than the external X. The external X is having a lot of screw loosening. Almost, based on Bynum, almost 40% of implants will unscrew, of abutment will unscrew on the external X. 40%. It's huge. So if you are like placing, I don't know, 1,000 implants a year, you are going to hire someone only to rescrew these screws that are unscrewing. By the way, if you get a screw loosening on an implant, you will not screw it again. You have to change the screw before screwing it again. You have to check the occlusion and you change the screw. Every screw that is unscrewed, you have to change the screw. Otherwise, you will break the screw in your implant, and problem will be bigger. So the external X is giving us more stability, less screw loosening, but still we have screw loosening, and we have a micro leakage, which is called the pumping effect between the implant and the abutment because of this gap between the implant and the abutment. Because in the internal X, the internal part of the abutment is going to be parallel to the internal wall of the implant. So if there is friction between the abutment and the abutment will never enter. So companies are going to leave some space, which is called the passive fit between the implant and the abutment, in order that the implant goes in. And this passive fit, this space between the implant and the abutment, gives us some kind of micro mobility between the implant and the abutment, and gives us may finish by a screw loosening or screw fracture. The most tapered connection are having a good seal, which is one of the best connection that you can have. It is having no screw, but we have a problem in the retrieval of the abutment. So it is not easy, it's not friendly to use. But from the point of view, from the stability point of view, this is what that can be the best and the best connection, but it's very, very hard to use. The conical screw, which is called the conical abutment, normal conical abutment, is now the best compromise between the most taper and the internal X. So for me, this is one of the best connection that you can use. It's easy to handle. It gives us a seal, and it gives us a stability for the connect. So here you can see, as I said, in the external connection, there is no there's no contact between the implant and the abutment here. No contact between the implant and the abutment. This allows this a micro movement between the implant and the abutment, and this may have a micro gap and may have screw loosening or screw fracture. Actually, I was lucky to get Ziprich as a Wiegel as a teacher. He was making this study. He placed an implant and he screwed the abutment on the implant. Then he put pressure on the abutment. The pressure was about 200 Newton, and the chewing force is about 220 Newton. So he was in the level and the limits of the chewing forces, and he saw that there is a micro gap that is opening here between the implant and the abutment. So this micro gap, what will give us this micro gap? Let us see it here. You see this opening gap. Once it's opening, this implant is placed where? Is placed in the bone. This part is in the gum, is masked by the gingiva, the gingival fluids, and once it opens, all the gingival fluids will enter here inside the implant. Once it's closed, these gingival fluids will goes out from the implant. And what's inside the implants here? What's happening here inside? We have here microorganisms, toxins, and all these things. These toxins will goes out with the fluids, and this is what is called the pumping effect. The fluid is going inside and outside, inside, outside. And when it goes outside, it brings with it all the toxins. The toxins will be fixed here around the bone level, on the bone level here. And what it would induce? It will induce bone resorption, because this is an inflammatory reaction because of this pumping effect. Here we can see Ehrman, a study that he did, which is very interesting study. He chose implants with microgap, both implants with microgap. But these implants, he linked all these implants together to inhibit any micro movements. There is no micro movement. There is a gap, but there is no micro movements. These implants, there is a gap, but these implants, they are still having micro movements because they are not attached together. And what was the result? The result, the bone was stable on the implants that are not having micro movements, while the micro movements around these implants induced these bone resorption. It is not because of the micro movement itself. It is because of this pumping effect that is bringing all the toxins that are here, bringing them out and inducing this inflammatory reaction. So if you are using an implant that's having an internal connection, an internal X, allowing this micro movement, there's no seal between the abutment and the implant. This micro movement is allowed, so you will have all these toxins inside that's going outside, and you are going to have bone resorption. While if you have your implant is making a seal, and there's no micro movement, there is no pumping effect, you will get more stability of your bone. What somebody will tell me, what if I use a switching platform? The switching platform is a great thing. No, actually, switching platform. Look at this study. We can see the bone loss around implants. The red one is the switching platform, and the yellow one is the standard or the matching platform. They are having the same bone loss, both the one having switching platform and the one having standard platform. So what is the importance of switching platform? Here it's the switching platform is not doing nothing. Why? Because these implants that are compared, the implants with switching platform and the implant without switching platform, those implants that are compared, they are having an internal hexaconical implant. So their connection, it's an internal connection. It's not a conical connection. With an internal connection, either having switching platform or not, you will get bone resorption because you are having this pumping effect. While if you are not using an internal connection, you are using a conical connection, a switching platform will play a very good role in distributing forces around the implant. Look at this study that was made. Here we cut an internal connection and we put the microscope. You can see the space between the implant and the abutment. It's microspace. For us, it's too small, but for microorganism, it's like highways. While if we look at this implant, it's a conical connection. We can see here there is no limit. This is the screw. This is not the space. This is the screw. This is this one. The screw. But just look and search for the limit between the abutment and the implant. You cannot see it. You cannot find it. It is like sealed. This is what we call by the cold welding. I don't like this term the cold welding, but this is what you are used to call it as a cold welding. So let us see some different implants on the market. We have the Straumann, we have the Noble Active, for example, the Onkelos, the Astra, and the Root, the Viper one, which is I'm in love with it, because there is a lot of modifications on this Viper one that makes the prosthetics easier, the implant insertion much easier, and especially the stability of the bone around the implant. So bone level Straumann, they are having, for example, like 16 degrees cone, but the problem of this cone is 16 degrees. First of all, it's 16 degrees. 16 degrees, it's a very wide cone. It's giving a seal, but it's a very wide cone. There's no, once you place the implant and you want the abutment, and you want to take it out, you can take it out easy. There's no stability. You may have some micro movements and you may have some screw loosening. And the problem is not on it. The problem is that these 16 degrees is only 0.5 millimeters. It's not long connection. Once you don't have a long connection, you are having an 0.5. It's like you are fixing the abutment only by these two fingers, but you are allowing some micro movement between the abutment and the internal part of the implant. And this micro movements are making some chips of titanium. These chips may induce a reaction, an inflammatory reaction, and the bone loss. Noble Active is having 15 degrees, which is not bad. The less is the angle, the more is the stability. The long is the angle, the more also the stability. So you have to have a long cone, with a closed angle. Actually, if we are talking about Morse cone connection, the Morse cone connection, the angle here is 5 degrees, the angle. So the 5 degrees from here to here. But one Morse cone, Stephen Morse, the guy is called Stephen Morse of this connection. He was measuring, like if you make a bisector here, the maximum of the angle between the bisector and the cone here is 2.5 to 3 degrees, not more than that. This is a cone connection, Morse cone connection. You don't have space to place a screw, but you will have a very high stability. So the problem is retrieving the abutment. So the compromising is to up a little bit the angle to be able to put a screw, but you still have this seal, this cold sealing between the implant and the abutment. So the closer is the angle, the better it is. The closer the angle and the longest is the cone, the better it is. So here we have Onkelos. One is 5.8 millimeters, 5.8 degrees, which is very good, and a long cone. But they have two problems. The first is that they are using titanium grade 2, as we said, not ELI, not titanium 23 that allows me to use narrow implants. So this implant may have some limitation in your surgery. Astra is having a long cone also, but it is 11 degrees. It's open. So if you can see here what we have, it's at 10 degrees. This is let us say 5 degrees, because Onkelos it's 5.8 if you measure it to the middle, not from the part to the part. Here, if you measure it to the middle, it is 5 degrees. It is less than Onkelos. It's having a longer cone, and it's having it's using the ELI titanium. So this is, for me, this is the implant that is offering me the best stability from the between all these connections. So the conical connection, the micro gap is almost 5 microns, while the internal and external is 60 to 40. The range tapered is from 1.5 to 5.7. 1.5 we are having like Morse connection. 5.7 it's a conical connection, but it's the best. And what is tolerated in the conical bone loss, but now it's not tolerated anymore. It's a 0.4 millimeters per year. So the conical connection, it gives us less bone loss on the margin. It's a superior bacterial seal. Here we are having a seal compared to the internal X. There's no pumping effect. Lower screw loosening, and you can see it for all those who knows this implant. If you place your abutment and you screw the screw, then you take out the screw, it will be impossible for you to separate the abutment from the implant, even if there is no screw inside. Why? Because of this conical connection. It is there. We have this seal between the abutment and the implant. We have this cold welding, and the abutment is very stable. So you don't all the chargers, the occlusion chargers, are not supported by this screw. So you will not have, or let's say you will have much less screw loosening or screw fractures. And this will improve the biomechanics. And if we have a switching platform, this is what we have the best. So here, if you can see it on the video, once you place the abutment and screw it, if you want to take out the abutment from here, it's impossible to take the abutment. Even if you take out the screw completely, you will not be able to take your abutment if you try. So you have to use an abutment extractor that will goes inside. This part will pushes down, and this part is screwed in the abutment, and you will retrieve it, will take it out. Otherwise, you will not be able to take it out. Because of what? Because of this seal between the implant and the abutment. So now, what is the improvement that we got in this Viper implant that I'm in love with it? But we got these grooves here that is making like anti-rotational, right? This is very interesting when you are going to after the osseointegration period. The bone will goes inside these grooves, and you will not have any rotation. There is no micro threads inside in these implants, and this will gives you a very high stability of the implant, the bone. And which is very, very interesting is the single and unique platform. The same abutment is going to match in all your implants. So this is why, as Dr. Salman said, this is why I'm using this implant since long time now, and I'm in love with the Viper actually. So choosing the right connection for a single cone. Let's choose the connection. Or if you are going to go the aesthetic, you can go conical connection. Single unit, also conical connection. If you are going for a bridge, you can go for external and internal connection. It's more easy to handle it in the prosthetic part. And since you are having a bridge, since this abutments are linked together, like splinted by several implants, splinted by the bridge, so you're not having these micro movements, and you are not having this screw loosening. So this condition, you can use the external X or the internal X in a full arch. As I said, if you are going to have to use a screw retained implant, it's much easier to use the multi-unit abutment, which is an external connection. And for immediate loading, you are going to use a conical connection. So each time you are you're having an implant, what I prefer to use is the conical connection, and only in case of multi-implants, bridge, a full arch, and I'm going to use screw retained implant. It is better to go for multi-unit. It's easier. What gives us the stability of the implant? There is two types of stability, as we know. We know the primary stability and the secondary stability. The primary stability is once I put my implant on the bone, I have to get my primary stability. The primary stability is the implant is stable. I place my implant, the implant is stable, it has no movement. This is the primary stability. This is what is called now also the ossifixation. The primary stability is nothing more than ossifixation, and the ossifixation is nothing more than primary stability. We are fixing the implant in the bone. Ossifixation. The osseo in English in French is bone. Os is bone, so it's bone fixation. We are placing our implant in the bone. We are fixing the implant in the bone. We are making an ossifixation. This is the primary stability. The primary stability can be measured by the insertion torque or by ISQ values. The insertion torque and the ISQ values will gives you an idea about your stability. So if you are having a high insertion torque, your implant is surely stable, is having a good ossifixation. But if your implant is stable, it's not sure that is having a high insertion torque. It may be stable with a 0 insertion torque. It is stable. But if it is having 25 insertion torque as such, 25 Newton or 35 Newtons, here you can be sure that it is stable. So it is like a relation a little bit strange between those two parameters, but let us make it simple. Implant stability is something that is, once we place it, is fixed on the bone. It is measured. How can we measure the stability? It's measured by insertion torque. So if I am inserting the implant, my ratchet breaks at 20 Newtons, the implant is stable for sure. But if I'm placing the implant and I start turning the implant, the implant continue turning around it, but there is no movement horizontally or vertically, only around its axis. So the insertion torque here is 0 because we have continuing the rotation, but the implant is stable. Okay, I think it's clear. If that's clear in the questions, we can develop it. So this ossifixation, this primary stability, is having a dip zone. Once we place the implant, we start having bone resorption around the implant. The bone resorption around the implant is the first step of osseointegration. Once you place the implant, there is a lot of osteoclasts around your implant, and they start eating or resolving this bone in order to repair the region, to replace this bone by new bone formation. So during this period, during the period of bone resorption around the implant, we are losing this mechanical stability or this ossifixation. We are losing it, and we start losing it. We continue losing it till 3 to 6 weeks. And then we continue, we start having this new bone formation, and we start having this osseointegration and the biological stability. Having this bone resorption around the implant once we place the implant. Actually, once we place the implant, the last drill, like let me take by example, if I'm placing an implant 4 millimeter diameter. The last drill is about 3.8 or 3.6 diameter. So you are making a measure, like a small pressure on the bone. Once you finish drilling a 3.6 millimeters diameter drill, and you are starting to place your implant with 4 millimeters, you are making pressure on the bone. And this pressure on the bone will make like let me say, directly necrosis of this bone. This bone will be destroyed, and osteoclast will come and remove all this pressure on the bone and will produce a new bone. So once you place your implant with a high stability, either you have an ISQ test, 70 is high stability, and this here you can go for immediate loading or early loading. 70 ISQ is like 35 to 40 insertion torque. 40 Newton. Medium stability, it's 60, and it's less than 60, it's a low stability, and you have to wait for 2 to 3 months before loading. It will be the period of healing. As we see in these studies, we have the immediate loading, we have 89% of success, 98, excuse me, early loading is 98. Also, the conventional, it's 96 to 98%. It's almost the same. So how can we obtain this stability? We know that we have different kinds of bone. We have D1, D2, D3, and D4. The one that gives you the stability in all conditions are the compressive implants. These are compressive implants. Why I put this one in compressive? Actually, the company root is calling this a compressive implant, but this one is compressive. Why? Because it's conical implant. The implant is having a conical shape, compress the bone, and this is why I put it in the compressive implants. But it's not its name commercially. It's my division of the implant, and these implants are giving you high stability in bone D3 and D4. If you want to place an implant and you're not going to make an immediate load on the implant, for sure I will not go for this kind of implant. This kind of implant is not having high stability because of two things. First, the threads are not as aggressive, and the implant is very straight. This is not indicated for immediate load implant. This can be indicated in bone D1 and D2 in order to reduce the pressure on the bone, because the more you have pressure, the more you have bone resorption. By the way, your insertion torque limit is 50 newtons. And do not go more than 50 newtons. Otherwise, you will produce crystal bone resorption around your implant. So 50 Newton insertion torque is the limit of your implant insertion. So if you are having an implant bone D3, D4, you will use these kinds of implants. And even if you are having D1 and D2, these kinds of implant is offering you also an advantage, and you can place them. You can just go for over the drilling a little bit, and you will place this implant, and you will not lose your primary stability and your insertion torque. So this is why I place these implants in compressive bone. Compressive implants, this is half compressive. The one that are having this is straight and conical. We call it cylindroconical implant. And the straight implants are non-compressive implants, and never go for an immediate load on it. In the stability, you will not have a high insertion torque on these implants. So look at this implant. This is why I'm telling you that even the 2 pieces implant is a compressive implant. We can see on this radio here, you can see the bone around the implant is compressed, is white, while here is not compressed. So even the implant, the one that is 2 pieces implant, is a compressive implant, and we can see it on this radio. The bone is condensed around the implant. This is why we have a high insertion torque, and this is why this implant, we can use it in D3 and D4 and obtain a high insertion torque and making an immediate load on this implant. So once we place the implant, as I said, we are looking for osseo-fixation. This is the mechanical part, but the second part, the biological part, is the osseo-integration. What we need, why we made this modification on the surface treatment, because we want to increase this yellow part, the secondary stability bone. The secondary, we would like to have it here if it's possible. So as fast as possible, this part is better for us. The more we have this yellow part, the better for us. So having this surface, sandblast surface, increasing this part, this osseo-integration part, and reducing the time of osseo-fixation. This is what we like to have. So what are the factors that affecting this primary stability? We said the bone quality. For sure, if you are dealing with a bone type D1 or D2, it's easy to obtain a primary stability, even with a cylindrical implant. With a conical implant, it's much easier. But even with cylindrical implant, if we are dealing with D1 bone or D2, it's easy to obtain this primary stability. While D4, the D4 is harder to obtain a primary stability. So in D4 and D3, it's better to use a conical, it's a tapered implant that offers us more and more stability for the implant, and to go for immediate load anyway, or to secure our treatment. Even if we don't want to go in for immediate load, we secure our implant placement and we secure our treatment by using these tapered implant, because we are sure that we are going to have our primary stability. The implant design, but it's related, which is what I was talking about. The implant design is related to the bone. The implant design, the tapered implant will achieve higher insertion torque than cylindrical implant. This is what we are talking about. A conical implant, a tapered implant, will give you very, very high primary stability, because it is compressing the bone. It is modifying the bone around the implant. The bone, which is a bone D4 and D3, it is modified by this pressure and this condensation. While you are inserting the implant, you are making condensation around the bone. This cancellous bone is transformed, like allow me to tell, like to be like a cortical bone. It's not a cortical bone for sure, but it will be condensed and dense, because you are compressing this bone, and this is why you are having this high stability. The tapered implant is very, very important in D4 and D3 bone. The surgical technique, if you are going, for sure, if you are going like using cylindrical implant in D3 and D4, you are obliged to make under drilling in order to obtain stability. Otherwise, you will not have it. And the implant stability is also affected by a long implant. The longer the implant, the better is your stability. So the factors are affecting the stability. This is what I was talking about. If you see here, the body of the implant is conical, this body of the implant, and this will compress the bone, and this will give you the stability. In addition, we are having aggressive and wide threads here, and these aggressive wide threads are localized where? In the apical part, and not in the crestal part. So this part with the pressure is made is not affecting the crestal part of the implant. And think at this, please. Here, what we have here, it's cortical bone. The cortical bone is not compressed bone. It's not able to be compressed. For sure, once the implant is touching the cortical bone, you will get a high stability. But it is not a compressed bone. So if you place here a wide, you are making high pressure on the bone, and you will make like micro fractures, and you may finish by some bone resorption. So here the implants are wide down where it is the cancellous bone, and where we are going, we need to have this compression, and we need to have this stability and this changing of the morphology of the bone. So the implant surface, we said, is also affecting the secondary stability. Why? Because if you are placing a machined implant, like those who knows me knows that I am not favorable for basal implants, because these basal implants are using machine surface implant, and this machine surface we are loading immediately on these implants. We know that the rule for immediate load is to have this 40 newtons of insertion torque. If you do not have 40 newtons of insertion torque, you will not be able to make an immediate load on the implant. So if you want to have insertion torque 40 newtons, you should have conical implant, you should have bone quality, okay? You should have threads, but also you should have an implant that having a surface that allows to increase the friction between the bone and the implant. If the surface of the implant is machined or smooth, I know we cannot talk about smooth implant because nothing is smooth. But if it is machined, the friction between the bone and the implant is not as high as if the implant is rough. The more the implant is rough, the more you will have friction. The more the implant is rough, the more you will have a high insertion torque. So if you are looking for a high insertion torque to make your immediate loading, you should use a rough implant surface and not a smooth implant surface. And this is why I'm against these kinds of implant. And this is why the implant surface will influence, will affect the insertion torque and the implant stability. Then we will not go through these systemic health and local biological conditions to get this stability, because it is more and more details and we don't have enough time. What I would like to add also in this lecture, something that only root companies having, is this GF0 cover screw. What we know is if you want to place an implant, if you want to place the implant 1 millimeter deep in the bone, subcrystally. By the way, do not place your implant, please, 4 or 5 millimeters in subcrystally. Do not do that, because if you are doing that, once you place the abutment after, you are creating an intraoral, infrabony pocket. So do not do that. Go till 1 to 2 millimeters of subcrystally. This is my philosophy, and this is what I believe in it. So once you place your implant, and even look, imagine you are going to close this implant here by the cover screw. Then you make your sutures. And what will happen after if you make your suture? Imagine you don't have this screw, you are having a small screw here. We know that the migration of soft tissue cells is faster than the migration of hard tissue cells, of bone. So what will happen? This soft tissue cells will go here and will collapse, and it will touch the implant surface. There will be not enough room to build bone on the implant platform here. While if you use this kind of screw, the cover screw that is having a space of 1 millimeter, it's acting like a tenting, keeping this soft tissue away from the implant. And the body do not like empty spaces. So the body will look to fill this space. And how is it going to fill this space? They don't have the choice. If you want to make any migration of this soft tissue inside to fill it, it's impossible because of this cover screw. It will not be able to go and to fill this space. So he has no choice than filling the space with this bone. So the bone will cover the implant platform here. And you're going to tell me, okay, and what is the issue? If this implant is covered, this bone is adding 1 millimeter here of bone, what is the issue of that? Why we are looking for that? Actually, we know that the difference between the implant and the bone and the tooth is that all this ligaments, all this tissues are having irrigation from ligaments between the implant and between the bone and the tooth, and vascularization also are coming from the periosteum. While we are using an implant, there is no ligaments here between the implant and the abutment. So we are not having blood supply here. We need to increase this blood supply. The more we increase the blood supply, the more the implant is stable, and the more the implant will defend against aggressions. So to increasing this, how we want to increase this blood supply, the only way to increase blood supply here is increasing the periosteum. So if instead of that periosteum stopping here, it will stop here, and will bring more blood supply to the implant, and the implant will be more stable in the long run. So this is why this screw is important. Each time you place an implant, even if you're not making it bone graft, each time you're placing an implant, please place your implant 1 millimeter of the bone crest and place your GF0 to have your bone growing on the top of the implant. So like this case, for example, we can see I placed my implant 1 millimeter under the bone. I placed my GF0 on it. In this case, I grafted the gap also, right? Because each time I make an extraction, I have to graft. We have to graft. And 2 months later, I opened it. At 2 months, this is the screw. I take the GF0, and you can see the bone growing around on the implant platform and supporting this this pygium and supporting this stability. Let us see another case, almost the same. We make an extraction of these teeth, of this tooth, placing the implant in the middle, in the septum, having this space between the implant and the abutment, 1 millimeter. The implant is placed subcrustally, 1 millimeter, placing our graft. This is the implant, and this is the GF0, and this is the graft. 2 months later, the same. We are seeing implant. Okay, we can say that it is like smooth, like soft here. It's not hard. Yes, because it's only 2 months. I opened at 2 months. I'm not telling you to open at 2 months, but this I opened at 2. So the conical connections provide the best bacterial seal around the implant. This is what we know. The platform switching is good, but if you use conical connection implant and not an internal connection implant, the SQ is a reference. Yes. The immediate loading, never do any immediate loading less than 35 newtons, and the implant should be long as much you can. You cannot go to make an immediate loading on an implant at 6 millimeters, even if it is 40 Newton centimeters. We are not going to do that. So a full arch immediate loading, you have to splint it, and it will have a very high stability. Here I'm I'm giving you some references that I used to prepare this presentation. You can take it in a picture. These references are used for this presentation. And just I want to tell you that a good surgeon is not the one who can use all the systems. Is the one that knows when to use the system, when to use this implant and this implant, not the one who is able to use all these systems, all the implants. So just do the good things, and do the thing good. And thank you for your attention. Salman.
Thank you so much, Dr. Mohammed. It was really nice and interesting. We have some questions during this. So one of the questions which is interesting is your opinion about one-piece implant. So this is again a very interesting, because we were discussing two-piece, and you always recommend that there are indications for everything. So yeah, please elaborate your opinion about this.
Yeah, the one-piece implant is actually, it has its indications. It's a very interesting implant. As I said, the advantage of implants, especially root that are using titanium 23, it allows us to use small diameter implant. So these kinds of implant, the one-piece implant, can be used in narrow ranges. The advantage of the one-piece implant is that having no connection, and as says always, the best connection is no connection. But we have two kinds of we have two kinds of one-piece implants. We have the one-piece implant, the classic one, the compressive. Okay, and we have the multi-unit one. The multi-unit one, it's not very complicated to use. It allows us to use to make several crowns, several bridge, and screw it. The problem that we are facing is with the implant that is bendable. This is what we have facing. Why? Because actually I saw a lot of doctors placing the implants, bending the implant, taking the impression, and making the prosthetics. And once you look at the prosthetics at the radio, this is catastrophe. Actually, especially when you are having 4, 5, 6 implants and they are bended, you will not be able to make it parallel. You will not be able to have a good fitting of implants. You are not going to prosthetics. But there is a solution. Fortunately, there is a solution. The solution is to use a telescopic abutment. If you get a telescopic abutment, you will have a very good fitting. But I don't know why, for some reason, I don't know, nobody is using this telescopic abutment. Maybe economical reason, maybe something. But actually, the implant, the one-piece implants are not different than 2 pieces implants. They are having the same materials. It's titanium 23. They are having the same surface treatment. They are having the same. It's not like magic. Okay, it is a solution that, let me say an example for a lateral incisor, up or down. It can be a very, very nice solution for that. So this is the condition. You have to know when to use it, not how to use it, because it's simply drill and you place it. You have to know when to use it. But it is a good solution for those who want to use it in multiple. Just please use the telescopic abutment, please.
So this is again one of the features of Root that we have a patent on this. This is called as a telescopic or a econometric solution. So it is screwless, cementless solution. It's completely what Dr. Mohib in his lecture presented, that it's a 5-degree conical connection which doesn't require anything. It's like a cold well abutment connection, not an implant abutment connection, but an abutment connection. So if you are interested in knowing this, you can go to our website. You can scroll down to the webinar by Dr. Daniel Karpavicius. So there's a very nice webinar about this specific treatment modality of econometric solutions. You can go and check, and also you can contact the local sales guy to understand more about the solution. This is one of the best solutions that you can have that will help you do your cases, especially when it comes to the one piece, which is the compressive ones with this monobody implants, monolithic implants. It will help you a lot. We have Dr. Safi. Can you please write your question in the box in the chat? Okay, one more again important question. This is from Dr. Sadiq. Hello, doctor. Do we have to use xenografting for gap for immediate implants? Can we use autograft filling the gap, because autograft will resolve more faster than the xenograft? So again, like this question is actually Pandora's box. Once you open it, you cannot close it. But Dr. Mohib, can you please give
this is a
answer?
very interesting question. Actually, each time you make an immediate implant, extraction, immediate implantation, we have to graft. We have to graft. Why? This is a long lecture. We can do it maybe later. But for making a summary, we have to graft. What graft we are going to use? Xeno or human or synthetic or what? The Xeno, as you said, the problem of the Xeno is not that is not remodeling. It will not resolve. The other one is resolved fast, maybe, but the Xeno will not resolve. The bovine, it stays on the implant. It stays on the place. This is why Boozer told us that if we want to make grafting on the implant, we have to make layering technique. We have to make something that is going to be remodeled, some like allograft or autograft first, and then we are going to place our Xeno. The advantage of the Xeno is that it will hold the volume for us. It will keep the volume, and the alloplast or the auto that is going to be resolved and replaced by patient bone. Otherwise, if the implant is always in contact with the Xeno and the Xeno will not resolve, if you have a peri-implantitis in this area, the peri-implantitis would be like fast and like destructive, because there is no integration between the Xeno and the implant. I don't know if I was so clear on it, but this needs a real lecture.
Well, this probably it's a topic for another webinar. So, okay, I have one more request. We have with us Dr. Ahmed. He is the head of sales, and he would like to invite all of the attendees for Dr. Moheb's course. To you, Dr. Ahmed.
Hello, thank you so much, Dr. Moheb
Thank
and
you.
Dr. Salma, for this beautiful webinar in the evening on a Saturday night. We will have a course in September with Dr. Al-Moheb on GBR techniques. It will be a 2 days course. It will involve, just let me, I need to show the, just give me a second. Need to share the flyer. Can you share the flyer, please? Yeah. I don't have it. I am unable to share it. Yeah, so the course will be speaking about the GBR. It will be yeah, it's there. So just give me a second. Yeah, so as a clinician specialist, we all know that there is an unspoken rule of implantology. Your implant is only as good as the foundation sits in. So when you have a bone defect, you will need to do the guided bone regeneration therapy. You need to have a good amount of bone in order to have a long-term success. So you will have to go and attend this course with Dr. Al-Moheb in order to have it. And to get more information, you will have to speak with your current distributor, and you will have to also contact our local offices. So do you have any questions on that? Would you like to, do you have any questions on the course? Yeah. Is there any questions?
No, none I can see.
It will be on between 11th to 14th of September. It will be, there will be a, yeah, there's a question. Dr. Wafi is asking a question. So we'll also leave a link with the, with all the details. And you can just, you know, as I mentioned, you can contact your local distributor or the local office. And if you have any question, like, you can ask. I'm waiting for any question. Like, there's an offer, like buying implants and getting the offer on the GBR. Actually, I have a lot of, I'm unable to share many things. That's why I'm unable to speak. Dr. Salman, are you able to just share the photos on the group of the doctor?
I'll do that. No problem. So I think they already answered.
I can't explain without having photos, and I'm unable to find them, because Dr. Moheb has had a lot of courses with a lot of delegates. It's very it's not full of people. Like, you have only 3 to 4 delegates there, and it will be a hands-on training. Like, the first day will be covering the theory, and the second day will be hands-on. And there will be a patient inside. He will be doing the GBR technique, and I'm unable to. I want to show. Yeah, exactly. So that's how he concludes his courses. So he will show you how it's done step by step. You will be there. It's going to be in Paris between 11th to 14th of September, and the prices are very good. I cannot share the price because each territory has its own pricing, and each distributor has its own pricing. You will get a kit, you will get 30 implants, you will get accessories, and also you can be referred to a bone graft company which can supply with xenograft and allograft, and you can start with the membranes, and he will show you the techniques that can be used in the guided bone regeneration with our GF and GFN0, sorry, and the GF0, the osteoprotectors that we have. That he will show you all of these techniques, how to cover your membrane, how to protect your bone graft, and how you will have very long-term success. I guess it's very interesting to see. Can you scroll and show more of the photos? The surgeries. I guess we had also one 6 years ago as well in Paris. Am I right, Dr. Moheb?
Yeah.
Yeah, and we had delegates from Africa as well, from South Africa. Couldn't open the.
That makes me feel a little bit older.
Yeah, it's very old. We will share also the link. The link is free to register, and then we'll contact you in private. So if you have any question about the content, I can answer. Like, as I just spoke an overview.
So I think we will reach out to each and every one of them who have attended and who have registered, and they will have a proper overview and briefing about how the course will be and how it will look. Before ending the session, we have questions from Dr. Safi from Afghanistan. So how many implants do we need for immediate load? Do we need it under occlusion? What should be the length of the implant for immediate loading? So again, it's a Pandora's box. So Dr. Muhammad.
Yeah, actually, an immediate load, we can do an immediate load on one implant, on a single implant. We can do an immediate load. And if you want to make an immediate load on single implant, for sure you are making your temporary out of occlusion. You are not making an occlusion on the temporary. Now, if we are talking about a full arch on the maxilla or on the mandible, you can go from six implants on the mandibular to 8 implants in the maxilla, and you have to splint it. And here you are not going to make it out of occlusion, because you are not able to do it out of occlusion, but you have to do a balanced occlusion, and the patient should eat something smooth, not something else. But there is something very important that you have to do. You are not going to use an acrylic temporary on a full arch. Why? Because acrylic temporary may break, and if there is a break on the acrylic temporary, you may lose your implant. You have to link this implant by something solid, like a metallic frame, or in the past we were doing something like intraoral welding. But you have to stabilize all your implants together, and you have to make like a frame for your temporary in order not to break. If it breaks, you will lose your implant. You will end by losing implants. I missed something, or this is the question?
I think it was a good answer. Again, it's a very comprehensive topic, and we need to discuss it in detail, because I think it's not a simple question to answer in such a short time.
Yeah.
So probably, I'm really happy to have these questions, because it just motivates us to bring you these topic as a webinar.
Exactly.
Give you more details. So I'm really happy from the questions that I got today. We will soon organize something more tangible for our audiences and the doctors and the routers that we're working with. And I think the next one, we hopefully do it for immediate loading and, and the protocol and the modalities. Apart from it, I think we are already quite ahead of the time, which was, we decided it was 1 hour. It's already 1 hour, 20 minutes. So thank you so much, Dr. Muhammad, for your time. It was really nice and interesting knowledge sharing experience for all of us. And we are looking forward for the course from you. And we hope we'll reach out to each and every person in the audience, and for them to give the details about your course. And then we will inform you accordingly how many participants we have got.
Thank you, and I would like to thank the audience for being here and to listen for us.
Okay, thank you so much. Have a great weekend. Bye-bye.
You too, bye-bye.